Welcome to our TALAHour today. Thank you everyone for joining us. A few housekeeping things right off. We are recording this and we have the ability to use the chat, which I will enable shortly. If you would like to ask questions during the presentation, please feel free to use that chat function. I'm Diana Martinez, President and CEO of TALAHour. And we're delighted to have with us today some folks from Insurica, one of our industry partners, Steve Groth and Lee Saylor. They are going to talk to you about some hot topics that we actually get a lot of questions about. I'm also delighted that we were able to have Carmen Sultan, our VP of Public Policy, join us so she can ask and answer any regulatory questions that come up along these topics. Because we do get a lot of questions about these two topics. And with that, I am going to go ahead and turn it over to Steve. And once again, Steve, Carmen, thank you for being here.
Thank you, Diana. My name is Steve Groth. I'm a commercial insurance broker and I specialize in senior living. And I actually spent 16 years to begin my career on the insurance company side. I began doing safety and health consulting, really with a focus on healthcare and senior living. So I've spent time, I've probably done 300-400 gate belt training sessions. I've spent a lot of time doing gap analysis of different programs. Then after that, I became a commercial insurance underwriter. So I was the guy who set the price. And now I do this, and I'm excited to be here today to talk about a topic that's very important to all of us. Here's the agenda for my portion of the presentation. I've actually got my colleague Leah. We're doing two separate topics today, so two separate 30-minute presentations. I'm going to be talking about safe resident handling and mobility. And just so you know, nobody was injured in the picture taking right here showing this transfer. This is a colleague of mine at a client. We were just taking some photos to be used actually as part of their quality assurance program. So we wanted to show the good and the bad, but we're going to talk briefly about why this is such an important topic. And I love this topic because throughout my career, it's one of those topics where I have learned the simple, effective tips from successful organizations. So I'm borrowing from a lot of successful clients and former clients today as we talk about some really good best practices. And then I'll get into a little bit of the cost benefit analysis as well. But I actually just thought I'd stop and share a quick story with everyone. I put together a little, actually I got to turn the right direction. Here we go. I put together a little whiteboard here to show several of the areas why this is such an important topic. You know, when we think about safe resident handling and mobility, a lot of times we think about staff safety, resident safety. We might even think about how can we control our insurance costs, and these are very important things. I just want to encourage everyone to really today broaden our perspective on all of the benefits that this topic has within our communities. I wanted to share a story from a client of mine. I've done a lot of work in my career in small towns, and I used to work with both assisted living communities in a small town. And let's just say one of them was a model provider. They were fantastic at everything they did. And the other had some work to do. And I would often meet with these folks on the same day. I'd meet with one in the morning, one in the afternoon. And I was meeting with the folks who had just a spectacular safety program. And they were concerned. They had heard that their crosstown rival, because they competed for staff, that they were raising their pay and they were not in a position actually to match it. So they knew that they were going to lose a lot of good people, and they did. Anyway, the next time I was out there visiting with them, this was a couple months later, they said, Steve, we have such great news that we need to share with you. They said, we got the majority of our staff back. And it's not because we raised pay, because we weren't able to. And the woman who actually did their gate belt training, and she was a phenomenal trainer, she said when they would interview people and welcome them back, they would say, well, what What made you decide to return? She said one of the most common responses was they said, here you care about our safety. Over there, they don't. And that was really impactful for from a hiring and retention standpoint. So that's just one of the other things I'd like to consider as we talk today. So first, I just want to jump into sharing my screen again. I'm very data-driven in my approach, and I think it's very important to take a step back and look at the numbers. The Bureau of Labor Statistics has annual employee injury data, and it typically lags behind about 2 years. And what this graphic shows is hospitals, assisted living, and skilled nursing facilities. And the rate that I use here is really my favorite benchmarking rate. So when I have a client ask me, hey, Steve, how do we compare to the industry? I usually go to the DART rate.
Hey, Steve.
Yes.
Real quick. We're not back onto the presentation. We're onto your super adorable baby photo.
Oh.
Home, the sort of, I mean, we don't hate it, but.
That would be my nephew.
There we go.
Okay. I hit the wrong screen.
Thank you.
Well, you're welcome, everyone. You can look at him rather than me. So this slide shows the 2021 BLS data. Now, why does this data matter? If we look at assisted living and CCRCs, what this is saying is that every year in the United States, about 5 out of 100 of our team members has a serious injury. DART rate stands for days away, restriction, and transfer. So it means there was a work-related injury serious enough to result in one of those types of restrictions on the employee. If you look at hospitals and you look at skilled nursing, I always like to compare these three because on a per employee basis, assisted living typically does more transfers and assistance than hospitals do. And then skilled nursing does even more. So as the level of the acuity changes, the amount of hands-on care and transferring changes, oftentimes the injuries increase. And also just wanted to compare also to a couple of other industries. If you look at manufacturing and construction, they're actually far below where these industries fall. There's been a lot of regulation in manufacturing and construction from OSHA, and these industries actually have historically had now better injury rates than assisted living. The good news is I have worked with so many organizations who do a fantastic job. And when we do their annual benchmarking analysis, they come in far below the industry norm. So there is hope, and there are best practices that we can put in place. I just wanted to share my approach when I was doing safety and health consulting full-time. I really had a 3-step process. My first step was I always looked at policies and procedures. Then I'd like to sit in on safety training. Like, how are you educating your people now? And I put green check boxes next to those because as an outsider, those are steps that I needed to take, but they're probably a little bit easier for the folks on the call because you're at your communities day in and day out. But the last bullet point, which is observing staff to see what are we doing well, where do we need some work. This is a constant process that every organization needs. And the higher the turnover, the more important it is. So actually, I've got a photo here. This is about from 10 or 11 years ago. But I literally learned the senior living industry. When I say effective time on the floor, I'm not saying be literal, get on the floor. But this is how I learned. This is how I learned what a day in the life was like. I was, I think, in my late 20s at this time. I don't get on the floor anymore. But when we are on the floor and we're interacting staff, what is the best approach we can take to learn where are we strong and where are we weak? And my recommendation, whether you have an elaborate quality assurance program or you're just starting to get one going focused on this topic, is simplicity is always a way to be consistent. I've had clients where when they're doing observations of staff, they will focus on one thing and one thing alone. And they will say, how are we as an organization right now doing in this one area? For example, how are we doing with where we stand during gate belt transfers? How are we doing with our hand placement? tightness of the belt, any number of things. We want to see how effective our training is. And the only way we can do that is if we get on the floor and we see what's going on. So again, quality assurance observations are the traditional approach. But what I learned is that if you can't observe real life, you can always ask staff open-ended what-if questions. Hey, let's say a gate belt slides up consistently on a resident. What do you do? When you ask staff those specific open-ended questions, especially what-if type questions, it's a great way to learn. And something that I've done a lot in my career is I'll just ask staff to transfer one another, just to show me how they do it, to show me what they know, what is getting through with our training and what's not. And this results in fantastic two-way communication on a one-on-one basis. And what I've found is that, yes, sometimes we find gaps within our training, which is more of a knowledge issue. Sometimes we find motivational issues that staff just don't understand why we do things the way we do them. And this is just a great opportunity to educate them on a one-on-one basis where it's a little bit less threatening than like a group training session. And then the last thing is you can record data and say, how well are we doing? The first shift, we were at an 80% safe score. Great. How can we improve upon those numbers? Now, the next topic is one, and by the way, so many of these things that I'm sharing today cost very little, if anything. And I think this is the biggest one. When you look at this topic, safety training, making it meaningful, I want you to think one word: culture. Effective safety training is a phenomenal way to improve your culture. And usually it doesn't require more time. It just requires a more thoughtful approach to how we approach the safety training. Now, think to yourself, have you ever been part of a safety training where you can tell that even the presenter didn't want to be there? Almost like they breathe a big sigh and say, okay, let's all get through this. I've seen a lot of that. The problem is that is such a negative for your safety culture and for your culture as a whole, because we're sending a message about how important our team members are and how important the people that they care for are. We need to instead have a really impactful hook in our presentation. So I encourage, during every safety training, start with an open-ended question that checks two boxes: the person's individual safety and well-being outside of work, and impact on the residents. If we can address both of those areas, we have a tremendous opportunity to improve our culture. My cousin's a CNA, and she's, the type of person I imagine everyone would want to hire. She always thinks about her residents first, always. And she's had injuries on the job, and I've asked her, well, how do you care for your residents if you're injured? Well, a lot of times we don't think about that until it's too late. So a couple tips when it comes to hooks. I encourage passing around, if you're going to ask one of those questions, pass around a sheet of paper and have people write things down. Due to my mistake, everybody got to see a picture of my nephew, but I'm glad you did now, actually, because if I have he lives 1,000 miles away from me. When I go see that side of my family, I need to get on a plane. And when I see him, I want to be on the floor. I want to be rolling around and playing with him. If I have a work-related injury, how can I do that? And people just don't consider this until it's too late, usually. So I encourage ownership by writing it down, and I guarantee your staff will say, okay, now who do I hand this into? And the answer is nobody. It's not for me. It's for you. It's for your family. It's for the hobbies that you love. And the second thing is I always encourage trying to be memorable and even funny. I've got two pictures here. First is just a kitchen. The second is getting into a car. I've had two serious injuries in my life, neither of which was work-related. The first was playing basketball. It was about 15 years ago. And the second was actually skiing. So the first was an ankle injury. I ruptured my Achilles tendon. The day after the injury, now kind of picture this kitchen, because this is what my apartment looked like. I was standing at the kitchen table with a bowl of cereal, and I realized something as I was standing there with crutches. How do I get this to the kitchen table without spilling it? And it became real to me that moment. I shared this story with a client of mine, and they thought it was so funny that they incorporated it into their safety training. They were doing a slip and fall prevention training, and they had 2 tables set up in front of the room with a plastic bowl and foam peanuts and a spoon. And then they had 2 crutches sitting there, and they said, "We need a volunteer." And they're telling me this just with big smiles on their face because it went very well. So somebody came up and volunteered, and they said, "Okay, you had an ankle injury. Get that bowl of fake peanuts, foam peanuts to that other table without spilling one." And apparently it was hilarious because they spilled them all. But that cost nothing, and it made the training impactful, funny, and memorable. The second was when I had my shoulder injury, it was on my left shoulder. And again, one of those realizations that life has changed was when I got into my car, I couldn't close the door. It was really difficult to close the door. And I was on the phone with my dad, and he's a big avid golfer, and he said, "Why don't you just put a golf club in the passenger seat and reach across and close the door with the golf club?" But sure enough, I had another client incorporate this into their safety training. They asked everybody to go to the parking lot. They had a sling. They asked for a volunteer. Somebody put the sling on, and they said, "Sit in this car and close the door." And they couldn't. And everybody laughed, and it was memorable. So this is just so impactful for your culture because it's a way of delivering a real message to your staff how much we value them and how much we value them outside of work. The next tip I want to share is it gets a little bit more technical, but it gets into the area of the importance of consistency with our assessments. When you have fully independent residents like the gentleman on the left, and somebody who's in a full sling Hoyer lift, actually from a professional liability and an employee injury standpoint, workers' comp, in my career, I've tended to see fewer claims on either of those ends of the extreme. It's typically more the gray areas where somebody is more transitioning from needing some assistance to much more hands-on with their ADLs to, okay, now maybe they are in a wheelchair. Maybe they are getting to the point where we need to consider things like mechanical lifts. It's really those gray areas where we tend to see the injuries because in our industry, we're not Amazon. We're not moving boxes. We can't say if it's over 40 pounds, you can't lift it. We don't have that luxury. So actually, Leah and I are very fortunate. We have a few folks on our team who have, just like Leah does, obviously, who are healthcare, have healthcare backgrounds. I have a colleague in our Birmingham office named Cedric. He's a doctorate in physical therapy. The two of us just wrote a newsletter talking about the importance of consistency in assessments. If you're one location, if you're 5 locations, most organizations have multiple different people performing assessments. So how can we be consistent? And the key is we need to find objective metrics that we can agree upon as an organization and then be consistent in our approach. Cedric is a big believer in the CDC 30-second chair assessment. Another recommendation we have to consider is just simple objective criteria for gait and pivot transfers. Can the resident sit unassisted? Can they take 3 steps forward, 3 steps back? I've worked with hundreds of organizations. I've worked with skilled nursing, and I've seen most people have different criteria in place, but the ones that are successful at preventing employee and resident injuries are the ones that are most consistent in their approach. And I thought I'd just take a pause from kind of these 5 tips because on the topic of assessments, it often leads to the question of different assistive devices out there, equipment. And I know every community is going to be different. Some may have mechanical lifts, some may not. Whereas obviously in skilled nursing, pretty much everybody has a considerable amount of lifts. But 2 devices I just wanted to share that I've seen in my career that I really like, especially for assisted living. The first, this is called a camel. It's for a situation with a resident fall where we don't have a serious injury. We just need to get them up. We need to get them up safely. And the nice thing about this tool is it allows us to put it out of sight. You can put it into a closet. It rolls up. It kind of looks like a tent when it's rolled up, and then we can get it when we need it. But it's one of those tools that can get people up off the floor. And then the second is if anybody's seen the Hoyer lift, that does all the work. I imagine some folks have seen the sit to stand lift, which is it's going to have a battery, it's going to have a sling, but the lift does half the work, and then the resident does half the work. This is kind of, from an independence standpoint, one level of where the resident needs a little bit greater strength and mobility. I believe Arjo's product is called the Steady, S-T-E-D-Y. And I really like this tool because it has no batteries, it has no slings. The resident does most of the work. So it's kind of one step between a gate belt transfer and needing an actual mechanical lift with a battery. And they're also much more affordable. I think they're $2,000 or a little bit under, whereas once we involve slings and batteries, we're usually over $3,500, $4,000. The costs go up significantly from there. So I just thought I would share two tools that I've seen used. And actually, I wanted to share one more story that I've seen that really impacted me, because one of the things that I've got up here is thinking about it from a resident dignity and comfort and safety standpoint. I was working with a client. They were considering getting mechanical lifts. They'd never had them, but they decided they were going to get one. And they ended up going with a sit to stand lift. And there were a lot of people who were concerned that the lift itself was going to lead to resident injuries. They were very concerned. And two of their caregivers, literally the first transfer they did, they told me this was the first time they used it. They were transferring the resident from a chair. And the second she started to stand, the resident actually started to cry. And the staff immediately set her down. They apologized. They said, "We are so sorry," because they had been transferring her more with like a two-person, kind of like a hooking transfer, reaching under the resident's arm and then grabbing the gate belt. They said, "We are so sorry. We'll go back to doing it the way we did before. We won't use this anymore." And the resident said, "No, this is the first time I've gotten up and it didn't hurt." And so if anybody's considering mechanical lifts, I'm not in the business of selling mechanical lifts. I'm in the business of reducing risk. So I just always like to have the conversation about the pros and cons as you make these decisions. So what I have seen in my career is residents who need a lift and they don't have one, or we haven't gotten to that point. And we need to keep in mind that they may be experiencing pain and discomfort, and we're not at a point where we can safely transfer them anymore. And that's why everything goes back to the consistency in the assessment. That is just so critical for the program. All right, I'm going to share again, and I'm going to do it right this time. Are we good? All right. Okay, so tip number 4 is really, and going back to that assessment, again, staff, our frontline caregivers aren't doing assessments. Clearly, they are not. But the key is they are the eyes and ears. We need to rely on them to be consistent in communicating with us. And one thing that I've seen that I really liked is I had a client that implemented what they called a Hey Therapy card. It's just a simple one-page sheet, and they had a lot of these available. This was for internal communication. Obviously, we're not communicating with residents or family members. This is caregiver to therapist or whomever is conducting the assessment. But basically, that I as a caregiver have identified that anybody can have a bad day, but I've noticed something that's more of a trend, and we might need to have this resident reassessed. But this is a great tool. It's something that I've seen implemented, and it greatly improved the communication at this community. And then the last tip I wanted to share was if anybody's doing like stand-up meetings or huddles or whatever you call them, this is a great time, kind of like when we're on the floor and we're taking a very narrow focus at one topic. This is another great opportunity to bring up one specific topic with safe resident handling and mobility. And it's a great way for two-way communication. So in 90 seconds, you can have a great dialogue. You can talk about, okay, how would we handle a situation where we're doing a transfer and the resident's gate belt slides up? And the usual response is, well, we check to make sure it's tight enough. Okay, what if it continues to do so? That's a different approach, but that's a great two-way conversation to have with your team. And one thing that I like to do with clients is help to develop visual quizzes. And this is by the way where I took that bad example. We were working with these folks. They wanted to have a tool to use during their small team meetings. And what they would do is they would just pass these out. Staff would circle safe or at risk, and then they would talk about it, and then they would go to work. And then what they did is they would actually post the quiz in their break room. So it was just front and center for people to be reminded about. So those were really the 5 tips I wanted to share. I just wanted to wrap up briefly with a little bit of a cost benefit analysis, more from an insurance standpoint. One of the things that I included on my list is, the better we are in the area of safe resident handling and mobility, the more we can prevent workers' comp claims and professional liability claims. When we have a resident transfer, there can be 2 claims simultaneously. You can have a claim for an employee injury and a resident injury. And then think about it. If you have a resident who's assistive too, well, then we could have 3 claims. And obviously we know insurance is very expensive. And so I just wanted to share some data from a couple of my industry partners. I'm sure everybody's heard of Texas Mutual, but for lost time claims, we're looking at just under 22,000. Average claims for all, and these are all resident transfers, are a little bit over 5,000. Actually, United Heartland is my former employer from a couple of years ago. And then CNA is one of the specialists in the area of general and professional liability, and they do a report every couple of years that shows common sources of allegations. And I'm sure this is no surprise, but resident falls are top of the list, followed by pressure injuries, and then improper care. And safe resident handling and mobility can impact a couple of these different areas. And then here's the average cost, and as you can see, it's pretty steadily going up. Now, what I will say is CNA's data here is nationwide. I imagine due to the tort laws in Texas, if we had a Texas specific, it would be it would be lower than this, but still just resident related professional liability allegation and claims can be extremely costly. I've got a list of resources here that I wanted to share. Actually, one of them was I have not yet done. NIOSH recently put together. NIOSH is part of the CDC. They put together some learning on safety cultures in healthcare environments. So I'm actually going to go through that. They're free, so that's something I'm looking forward to doing. But I thought I'd just, if you've noticed, I do like sharing stories, because when I see the things that impact me, I just hope it can impact all of you. One thing that I have on my list is continuity of care. I like to close presentations on this topic with really a personal story about honestly when my job became a career. It's probably about 10 years ago, actually when my grandmother was on hospice care. And at the time I was doing safety and health consulting with, again, senior living, home health, hospice. And my job truly was kind of a job. I was in my late 20s and I didn't really fully grasp the impact of what I was doing. Truthfully, until I saw my grandmother. I was able to see her a few times while she was on hospice care. The first time I saw her, I walked in and the first thing she said was, "You have to meet Julie." And it wasn't, "Hi, Steve, nice to see you." Of course, she was happy to see me, but she loved her hospice nurse. And of course, she told me all about her and our family. It was a true blessing. We had a wonderful caregiver for my grandmother. I lived about 3.5 hours away, and on my 3.5 hour drive home, I don't think I had the radio on once. I just did a lot of thinking. And one thing that I thought was, since again, I see employee injury data, I know how caregivers are injured on the job every day, how they miss time, how they need to have modified duty, they can't do their full work. I just thought to myself, what if her caregiver is like repositioning a patient in bed and has a back injury? That would have been extremely hard on my grandmother and our family. Because I don't care who that next caregiver was. It wasn't Julie. And so this has really become personal for me, and because I see the value that the best caregivers provide, and not only for the resident but for their families. And so this is such an important topic, and I just really appreciate what you all do and what your teams do. So thank you so much for your time. I'm actually going to hand it back over. And my colleague, Leah Saylor, actually, I've got my contact information here. Feel free to reach out anytime if you have questions. Also, if you notice, I love stealing good ideas. So if you have something that works, I love to hear about it, and I'd love to share it with others. But I'm going to hand it off to Leah. She's on my team at Insurica. She's our clinical risk control consultant, and she's a nurse, and she's going to talk about respiratory protection today.
Hello, I'm going to attempt to share my screen. There we go. Hopefully that's working. Okay, well, my name is Leah Saylor, and thank you for having me today. I'm a nurse. I've been a nurse for 20 years, and the last 11 years of my career was spent in a 28-bed acute care hospital. And while I was there, I had the experience of getting to try lots of things while I was there. I've been all over the place in the hospital, med-surg. I've worked in employee health and infection prevention, among other things. The last 5 years, I was in quality risk and compliance. And today we're going to talk a little bit about your respiratory protection program. That is kind of a hot topic. And we are going to just go over the current program requirements and hopefully give you some tips and strategies to help you be successful with your program. And so this first slide is just a little informational slide. It kind of gives you the gravity of your respiratory protection program and why it is so important. And of course, you can see your date range up there at the top, 2021, 2022. And I think we all know that COVID kind of really shined a big light on respiratory protection overall. And so we're going to talk a little bit about your program requirements. This slide tells you everything that your program needs to address. So your written programs with your policies and your procedures. Your program administrator, and the guidelines say that your administrator needs to be a qualified administrator. And so the way that you address your qualifications for your administrator is by looking at the hazards that exist in your workplace. So if you have a lot of some industries are more chemical, other industries like healthcare are more infection prevention. So it doesn't say who has to be your administrator, just that they are qualified and that you have selected someone that is comfortable running your program and can answer questions and be helpful. Your hazard evaluation and respirator selection, and we will go over the hazard evaluation here in just a little bit. You need to have medical evaluations for your employees prior to fit testing. And then you need to be fit testing your employees, address proper use and storage. They need to know how that they're supposed to use this PPE or protection. They need to be trained on how to use them, what they're for, and where they can find the PPE in your community. And we never know if our program is effective if we don't evaluate. So we need to, at the end of the year, go through and make sure that everything that we had going was successful. And if not, what did we do to make improvements to that moving forward? And then record keeping. And this slide is also down on the resources page at the end. I have most of this stuff that's here is printable or accessible. There's links down there. And so this is one of those things that if you would like to print that out, that is there for you. This is just kind of a quick guide to your program. And so the hazard evaluation, when I was first researching about this program, my brain makes things very difficult and hard. And so after thinking about this for a little bit, I was like, just keep it simple. And so my advice is to don't recreate the wheel. Utilize your infection prevention policies, your infection prevention plan. All of our plans and policies need to complete a loop, and they all need to reflect off of each other. We all need to have the same message with all of our policies and plans. It all needs to work together. And so your respiratory protection plan and your infection prevention plan will work very nicely together so that you're not having to recreate the wheel and make it something very difficult. And this spreadsheet here is a risk assessment from the CDC, and I've put the link here. And then you should be able to utilize this for both of your programs. It should work very well, and it looks like a fairly easy tool. Okay, and then these are just some signage. If you need signage, these are there for you as well in the resources, just for you to be able to have those if you need them. So we're going to talk about a little bit of some tips for success on orientation, new hire, and when you're onboarding new people. It's a great time to get some of this stuff out of the way all at the same time. When they're when they come in to fill out all of that new hire paperwork, go ahead and have them fill out that evaluation. If they need, that's a great time for you to say, oh, hey, you don't meet criteria and they need further evaluation. Or if they do, you can go ahead and fit test them while they're there. If they need some people may request a copy of your respiratory protection plan. This is a good opportunity for you to be able to present that to them as well. And then training on donning and doffing and when to use the PPE. So the hospital that I worked at in our new hire orientation, we had an agenda that had a bullet point list of everything that we covered and did in orientation. And out beside every one of those bullet points was a place where the employee could initial that they had gone over that. And it was a one-stop shop for that documentation and acknowledgments that you need for your plan. And so anything that you're going over in orientation, you can put that there. There are a lot of videos out there. I believe the CDC has some really good videos on donning and doffing. Of course, you're going over that when you're fit testing as well. But those videos are also very helpful to have in orientation, just in case they need a quick refresher. And you can just have that one-stop paper form there that kind of really helps you with all of your training and some of your documentation. So part of the documentation that you need to keep and have on hand, that medical evaluation, and if they have any kind of physician documentation that goes along with that. You want a fit test record that goes along with the date that they were fitted, the size that they were fitted to, and the brand. And I think I'll be going over the brand information here in just a little bit, go over that a little bit more, why that's important. And then acknowledgement of the plan and policies and how they can access those, whether they had a hard copy or if, where they can find that information if they need to look at it at any time. And then you want to have documentation again of the training that they received. So here's an example of a fit test record. And this may be down in the resource tab as well. For internal documentation, so I spent about 4 years in employee health and infection prevention. In the hospital that I was at, we had about 200 employees. And so I created this real simple spreadsheet to kind of help keep me organized. And so when everybody came in at new hire, we did TB testing, fit testing. And so we did TB testing on an annual basis. And fit testing was done on hire as needed. And on an annual basis, we had a skills fair every year where anybody that needed any kind of paperwork done, whether it was HR, life safety, any of that stuff, we kind of hit everything all at one time. So we did a mass fit test during that time as well, just to kind of get all of that done at one time and organized. This spreadsheet really helped me. Say I was due in May for my TB test. In April, I would start sending out reminders. Hey, you're due for your TB test, come see me. This was just a really easy way. So I had the mask sizes. If anybody forgot what size mask they needed and what brand that they had, all that information was right here and very easy to access. So let's talk a little bit about your fit testing frequency. And we want to fit them on hire, preferably before they hit the floor. That way they are prepared with their safety stuff and their PPE, and before they go out into your community. We need to be refitting on an annual basis, and then as needed. So there are several things that can happen for an as needed fit test, and it involves anything that changes the shape of your face. Especially right now, we have a lot of weight loss medications on the market right now. People are doing Ozempic or Wegovy or all of those things that are out there, those wonderful medications. And people are dropping a lot of weight. And when we lose weight everywhere. That includes your face. Dental work, if you're having teeth pulled or root canals, that can affect the shape of your face. Cosmetic surgery and any kind of trauma, if anyone's been in like a wreck or anything like that, or just injuries to your face, any of those things can cause the shape of your face to change and your mask may not fit anymore. So just kind of keep an eye out when people are out and coming back to work that they may need to be refitted. And we are going into cold and flu season, unfortunately, again. So just keep an eye out for those types of things. Purchasing supply tip. So unfortunately, all brands fit differently. So if you're wearing a small mask in a 3M and you pick up a different brand to supply to your employees, that small may not fit them in the different brand. So every year when you're fit testing, when you're bulk purchasing some of those things, try your best to get everything in one brand. That way, when your employees are reaching into that cabinet to grab a mask, they're limited on what they have access to, and that's going to lower the risk of them getting into a mask that could possibly cause them to have an exposure. And we always want to make sure that all of our shifts have access to PPE at all times, and that it's easily for them to get to. And so let's talk a little bit about OSHA exclusions. Some people may wonder if their community is excluded from OSHA. The term employer means that a person is engaged in business and has employees. So business owners with no employees are generally not subject to OSHA. So if I'm self-employed, it's just me and I don't have any employees, OSHA doesn't pertain to me. Now, if I have 10 employees or less, I have a partial exemption, and that applies to recording and reporting. So documentation. You don't have to keep strict injury and illness records for OSHA with 10 employees or less. And that means that you have to have that number of employees throughout the year. You can't go over. The only time you may have to provide information is if it is requested by OSHA. And even though you have that reporting and recording partial exemption, if you have any kind of, required reportables, such as fatalities, inpatient hospitalizations, employee amputations, loss of an eye, like there are certain criteria, you do still have to report those things. And there is a link down there at the bottom if you need to look at that information any further. Regulatory body functions. I want to talk a little bit about OSHA versus the state. So OSHA covers workplace safety. It covers worker safety. So your employee safety. The state looks at patient or resident or community safety. So the state does not enforce OSHA, and the OSHA does not enforce the state. However, those two, kind of like your policies and procedures, how they all kind of echo the same message, these two overlap in a sense of one thing can affect the other. So is the community at risk from an infection control standpoint, which it is going to include your community safety versus the worker safety. If your workers aren't being safe, your community may not be safe. And so there's that little bit of overlap there where they kind of, safety is the message. And so one example that I like to give is about wearing gloves. So as a nurse, I wear gloves to protect me from you and to protect you from me. And so that's kind of how these agencies work. They kind of overlap and echo kind of the same message. It kind of blends together. So here are all of those wonderful resources. I do want to point out that the Small Entity Compliance Guide for Respiratory Protection, that second bullet point there, is a wonderful resource. It has a lot of checklists there that you can utilize to make sure that you've touched all those bullet points in your program to make sure that you've addressed everything. It's a really great resource. Those checklists are wonderful. And then there is my information. If anybody has any questions or if I've left anything out, resources that you may want or need, please feel free to reach out. And that's all I have, unless there's any questions or comments.
Thank you, Leah. Appreciate that. I do want to have Carmen address a question that we get all the time. I really do mean all the time. We frequently get a question about, can we use mechanical lifts in assisted living? And Carmen, why don't you take that? And this is from a Texas regulatory standpoint, everyone.
Yeah, so Diana's right. We get this question a ton, and the answer is yes. You can use a mechanical lift. It's got to be prescribed by the physician, and it has to be followed, right? Your staff in sort of how they utilize it have to follow the protocols and recommendations issued by the physician and then by the equipment itself. And Steve and I actually had a really interesting conversation about this because there's an injury component. There's a sort of a worker risk by using that equipment inappropriately. There's also on the regulatory side, when HHSC, the Health and Human Services Commission, is in your building and is evaluating like your fire drills and your emergency preparedness plans. If you've got a bunch of people who require like 2-person lifts, and you don't have staff, like if you only have a single staff person overnight, they'll cite you for that. That's a failure to have sufficient staff. And so I think it's always you have to be really careful when you're looking at or evaluating whether a resident is appropriate for your particular community, because you have to think about not just, okay, can this person use this mechanical assisted device? Yes. But will we, as their assisted living provider, will we have enough staff often enough, right, consistently enough to be able to use that device safely, appropriately, and sort of as prescribed by the physician? And that's not always a really clear answer, particularly when you're looking at those overnight hours. And the agency has increasingly been focusing on some of that sort of stuff when they're coming in and they're doing their surveys. If they're coming in even on a complaint, they'll sort of look at your drills and your emergency preparedness plans. That's been a big one. There's a big one right after Winter Storm Uri, right? There was an article that made the rounds in Texas media where there was a property. It wasn't even an assisted living facility necessarily, but it was a property that had a bunch of residents on higher level floors, and they didn't have enough staff to get them down the stairs. And of course, during Uri, there was no electricity, right? So it has increasingly come under scrutiny. And I think it's really important, not just, this conversation today is about sort of worker injury and workplace injury and avoiding all of those negative outcomes. You have a business component to it too, which is your license is at risk if you fail to follow those appropriate standards. And sort of like what Leo was saying about, you've got your own infection control and infection prevention practices and policies, right? From the regulatory perspective, HHSC, when they come into your building, they will evaluate your property on its compliance with its own standards and rules, right? So there's certain sort of minimum expectations, but really what they're looking for is, if you say your staff will wear an N95 when they are working with a resident who's COVID positive, and they come into the building and your staff's got it slung over one ear, well, then they're going to cite you for failure to follow your own policy, regardless of whether you are or are not, whether you've got sort of a partial OSHA exemption. So just really keep that in mind when you're developing your own policies. I think Steve's presentation was really accurate and said, keep it simple. There's the sort of the clearer it is, the easier it will be to follow, the easier it is to follow, the less likely you're going to run into some sort of wonky situation. And Lee is exactly right. We're coming out.
I think you may have froze up, Carmen. You did. All right. Sorry.
Diane, actually, I was just gonna expand on what Carmen's. I agree with everything Carmen said. I was. By the way, I really respect how y'all have to really balance, these various regulatory sides. You've got OSHA, you've got the state. I mean, your jobs are a challenge. And just two quick things. The first was, and I've never seen this in assisted living, but in my career, I have had clients with Hoyer lifts that have fallen over. Very scary incidents when they happen. And every time one caregiver, it's in clear violation of their policy. The second is, now jumping over to the OSHA side, Leah did a nice job of sharing OSHA citations for assisted living. By the way, those in the grand scheme of things are actually not huge numbers, less than $500,000 cited industry wide. I mean, there are industries where that number is 20 times that. It doesn't mean we don't take it seriously. We absolutely do. And this brings in the point about the difference from an OSHA standpoint between a serious violation and a willful. A willful violation per OSHA, the penalties are going to be multiple. You can multiply it by 5 to 10. It's going to be much more expensive. And if a manufacturer says you need 2 people, and either through policy or practice we don't have that in action, that's when we're really exposing ourselves also from an OSHA standpoint to much more serious violations.
And to Carmen's point, from a regulatory standpoint, people are like, well, I can help this person with a lift. This is great. But always take into account what that means to, do you have enough staff on hand, especially at night, in the event there's an emergency? Do you have enough staff to be able to assist that person, as well as your other folks in your community? And that's the little wrinkle that sometimes people don't think about when they accept someone that needs a lift, or they have someone that develops a need for a lift. You always have to make sure you have that staff component to take care of that person. Carmen, I'm going to ask you one more question that we get fairly regularly, and yes, you are back.
Sorry.
That's okay. Steve was able to take over that train really, really well. So all of us together are doing a great job where we're helping each other out here, which is just like their communities, right? But we are still getting questions of, are there any particular COVID-19 restrictions or requirements around masking right now? We get that question actually fairly frequently as well. So why don't you answer that one as well? This is obviously from a regulatory standpoint.
Okay, so if I cut out, here's the short and simple. HHSC will not mandate a masking policy. They will mandate that you have a policy, that you have an infection control policy. They will strongly suggest you follow the CDC, which has all sorts of COVID guidance around types of masks and types of individuals, right? So if you have a resident who's got an active COVID infection, that staff should be wearing an N95 and all of that sort of thing. And then OSHA has its own, again, overlapping or dovetailing, as Leah suggested, its component, which is also that sort of N95 with exposure or preventing exposure. From the state's perspective, they're not going to tell you. They are going to check to see that you are following your own, but you are required, depending on how large your community is, to follow OSHA's standards, all of which sort of points back to the CDC. So, yes.
Thank you.
And then I will actually, one thing I will bring up real quick. Every community in their emergency preparedness plan is supposed to address a pandemic. So you have to have respiratory, sort of policies or respiratory prevention policies in your emergency preparedness plans. So you can't think, I never have to think of this again because COVID is done. No. You are required to have it in your emergency preparedation. Oh, I cut out.
You cut out, but you came back.
Okay.
All right. Does anyone have any questions? I want to thank our speakers. It was great. Really enjoy that. And I really like when people do presentations and they bring in examples and they bring in real life things that are happening. I just think it makes it that much more memorable for us to think of those things at a later point in time. I want to thank you again all for joining us for our TALA Hour. We've got a couple of things coming up. We've got a TALA book event on the 7th. This is a beautiful book of a lady, Kathy. Her husband developed early onset Alzheimer's. She's here in Texas and she wrote a book about their journey. And it's a beautiful book. It is a fairly quick read. You can get that on Amazon or some of the other book vendors out there. You don't have to read the book to join us, so please join us. We will be with the author of the book, as well as Holly Glover from James L. West, who has worked in this area for a long time. And so both of these ladies are a wealth of information, and I think it's going to be very heartfelt discussion. I promise I will try not to cry, because I did cry when I read the book. It was beautiful. And then of course our next TALA Hour will be on the 15th, where we're going to actually have some culinary demonstrations around memory care. We asked folks what they wanted in this area and we did a survey, and so we're going to talk about some of the things that they wanted to see from a culinary standpoint in memory care dining, and so that should be really, really fun. This will be the kind of first time we do something where we're got someone that's doing a demo, so fingers crossed everybody. And then of course we just launched a leadership development series, which is a 4-part online series for those folks wanting to kind of step up and start looking at becoming in a managerial role in assisted living. We hope they check it out. We cost it very affordable for folks to be able to take that. And we really thank our workforce development committee that developed that. It's a great 4-part series, so please check that out. And then of course, save the date for a conference for next year. It's going to be in April of 2024. We're going to be in San Antonio at the Hyatt Hill Country next year. So the team's really looking forward to that. We've got a lot of great things going with that. And our theme for this next year is going to be Texas music. So we're all very excited about that. And with that, Leah, Steve, thank you once again. Carmen, thank you, of course. And we hope to see y'all next time at our next TALAHour.
Thank you
Thank
for
you
the
very much, everyone.
Thank you.